Welcome to the CEN Show, a platform where we learn from the world community. I'm your host, Rashaki Maskani, and on the panel this evening, we have the Fab Five, Professor Rahh, Ernest McBride, Jr., Brother Mshinda, and Brother Rahh. And we have additional panelists this evening. We have Dee and Adrianne, which are family members of the guests. And then also, I want to thank Brother Rahh for inviting his cousin to do this presentation this evening. Thank you, Brother Rahh. Appreciate it.
No problem. Thank my beautiful cousin. Yes.
Okay, let's continue here. Now, our guest for this evening is Dr. Iyantta Howell. She's, like I said before, she's cousin of Brother Rahh, and he is responsible for her being on here this evening, and I surely appreciate that. Now, Dr. Howell, I would like for you to sort of tell us about yourself and any information you want us to know, and then you can start your presentation. Thanks for coming this evening.
Yes, thank you. I'm so happy to be here. I am born and raised in Detroit, and I attended for undergrad at the University of Michigan, and I have been practicing for about 17 years now. I graduated from Wayne State Medical School in 2008. So I've worked in a lot of different clinical settings. I worked in prisons, residential treatment facilities, partial hospitalization programs, inpatient programs, clinics, and just saw a lot in my training. And I'm certified to work with adults, but I also took an additional 2 years of training at the University of Pennsylvania to study child and adolescent psychiatry. So that's the crux of the patient that I see are those who are like 18 years and younger. But I enjoy working with all age groups, and yeah, I'm just happy to be here and talk about this very important topic that I deal with on a regular basis. So yeah, that's just a little bit about me. So the title of my talk today is The Impact of Mental Health Stigma in Communities of Color. So I do have a few learning objectives. You want me to jump right in, right?
Yes. Please.
Okay, I just want to make sure. Okay, and then the format of this talk really is not extremely formal. I'm going to go through my talk and, just run through it. And then if you have questions, maybe you can jot them down. And then toward the end, we can kind of discuss it more. I'm not going to take a long time. So just so you know. But yeah, so a lot of my objectives for this talk, there's quite a few, but the main ones are really to understand what the term of communities of color means, to define what mental health stigma is, to explore common causes of mental health stigma, to identify examples of mental health stigma, and to examine how this stigma really impacts or really impedes treatment, and discuss ways to, really combat mental health stigma. So we all know this, but just in case there's someone in the audience who doesn't know what the term people of color means. So the term people of color is just a term used to describe any person in the United States who is not considered white. So, we have Black or African Americans, we have Asian Americans, Native Americans, Hispanics, Pacific Islanders, Middle Easterners, you name it. But for the purposes of this talk, we'll really be talking about, African Americans or the African American community. So stigma is basically, the term of stigma basically means a mark of shame or discredit, or basically a stain. So mental health stigma is just that. It's really looking down on a person who has mental health issues, or being judged, criticized, or avoided because of a mental illness. And of course, there are tons of different types of mental illnesses. You have depression, anxiety, bipolar, substance abuse disorder, intellectual disability, formerly known as mental retardation. So these are things that you know, a lot of people, of course, are comfortable sharing, well, I have diabetes or I have, asthma, but no one really talks about mental health issues, right? So there's like a stain on it. A lot of people think that, they can't talk about it because they'll be judged. So that's pretty much what mental health stigma is. So what does mental health stigma sound like? So you've probably heard some of these phrases, but a lot of what I hear in my profession are things like, what goes on in this house stays in this house. Like a lot of people have put off treatment because they were always taught that, what goes on in this house stays in this house. Or a person saying, I'll just pray about my mental health issues, or, that person's crazy, or really they just need to snap out of it, right? Or someone may say to someone who's struggling with a mental health illness, hey, did you take your medications today? Which really is demeaning, unless you have a really good relationship with the person, that's really a demeaning statement because it implies, well, I'm on you're on medications, but I'm not. So I'm somehow, better than you. Or some people feel like, if I really tell my therapist how I feel or, how much I've been struggling, they're going to lock me up or they're going to put me away. Right. So these beliefs are really stigmatizing attitudes that don't really reflect ideas that would really promote seeking treatment for mental health issues. So just kind of breaking them down a little bit more, the statement, what goes on in this house stays in this house, um, basically describes the temptation to really hide things that are going on behind closed doors in a person's home or family. So they may be tempted to hide violence or dysfunction that occurs in the home, or maybe you have a parent who's struggling with alcoholism or even other substance abuse issues, or say there's not enough food in the house, just different things that go on in the house that really should be shared with someone who's trusted so that you're not, suffering in silence. Because if you're not intervening in instances like these early, then it can definitely set up the basically an increased risk for the development of mental health issues down the line. So children, for instance, who grow up in very violent homes or where there's a lot of chaos going on, if you intervene early enough, you can really prevent a lot of mental health issues. But a lot of times we don't intervene because we hold on to these, stigmatizing beliefs. Um, so basically, if you keep these issues hidden or quote unquote in the house, it's often done as a way to protect the family's name. So the idea is that if I air my dirty laundry, then I'm basically admitting that, our family failed at really handling our problems internally. So these are the things that, when I have patients who come and see me, I often wonder, well, why didn't you come sooner? And I don't always say that, but I wonder a lot because I know had they come sooner, we wouldn't have as much to work against in terms of the severity of the symptoms, the morbidity and mortality associated with, when symptoms have kind of gone on for a very long time. Because not only do parents suffer from their mental health issues, but if they're expected to parent children, those children suffer because the parents aren't really capable or present to meet that child's needs. So um, also in terms of, the one I see a lot, which is I'll just pray about it. Because I grew up, in addition to my training, obviously, I grew up in a home, which a lot of African Americans did, a home where faith and Christianity was very much, valued. So sometimes there is an overvalue on spiritual interventions, and definitely, I'm not saying that prayer is not effective. It is. It definitely is. But I think some people erroneously view prayer as a static or a very passive act where I'm praying and there's really nothing else that I'm doing. But true prayer is faith filled, and faith implies action. So if you're praying, I think the way that the Bible intends for us to pray, we'll come up with solutions, right? So you pray and ask God to lead you, and then you wait for an answer. And oftentimes he will put people in your path. He may, let you come across a resource, and then that's an answer to your prayer. But if you're just praying and not doing anything else, then it's really a way to stay stuck. So I do see that a lot. And there was an article that really talked about mental health, culture, race, and ethnicity. And there was a statement in it that I felt was very, very pertinent to the conversation. And basically it says that through mutual affiliation, loyalty, and resourcefulness, African Americans have developed adaptive beliefs, traditions, and practices. And today, their level of religious commitment is striking. Almost 85% of African Americans have described themselves as either fairly religious or very religious. And prayer is among their most common coping response. So, again, prayer is important, but you have to do something, you know, in response to the answer that you get in prayer, right? So if you use prayer simply as a means to neutralize negative emotions, it's not really going to work. And I see a lot of people in my office who have prayed, they've read their Bible, they fasted, they recited scripture, and those things are important. But oftentimes you're trying to address a biological, medical illness with a spiritual intervention. And it's not that you can't use that, but that can't be your only intervention, because a lot of people, unfortunately, have had really bad outcomes, even though they were people of faith. So that's kind of what mental health stigma sounds like. And an example of what mental health stigma might look like is the uncle in the basement, right? I don't know if you guys know what I mean by that, but you know, we grew up with an uncle in the basement, an uncle who was like put in the back room of the house, right? So this was the uncle who had some kind of unknown mental health issues. And because no one could really understand their behavior, maybe they did bizarre, unusual things, they were delegated to a part of the house that was hidden and away from everyone else. So what message that sent to other family members is that, you know, you did not want to be like this person, you should stay away. And who knows if the uncle, you know, and it could have been an aunt or a cousin, but who knows if that person who was delegated to that back room didn't want to communicate or socialize with the family. But again, they were delegated to a part of the house that, you know, sent the message that this is this is an issue that really should be ignored or just avoided. So I oftentimes see that, you know, and a lot of times we as people, not just African Americans, but we as people do avoid things that we don't understand. And sometimes that means avoiding people with conditions that we don't understand. So that can definitely be stigmatizing. Um, Another stigmatizing belief is that a lot of people may accuse someone with a mental illness of faking their symptoms. Again, we often will delegate a meaning to something that we don't understand. And if if you're a person who's never actually had a mental health disorder, it is hard to understand what that person's going through. So it's easy to say, well, they're making up their symptoms, and you want them to snap out of it, but unfortunately it's not that easy. But a lot of people with mental health issues have been accused of faking their symptoms just to either get attention or, you know, I do see that a lot. So reasons why mental health stigma exists, there are actually a lot of reasons, but some of the more common ones are really within the African American community. We typically have a strong distrust of doctors based on this country's history of medical exploitation of Black people. And that's a reality. You know, a lot of people in our communities are not trusting of doctors, and there's good reason for that. I mean, there's been documented facts that, you know, we've been preyed upon, we've been lied to, we've been experimented on, and those things have repercussions down, you know, they have longstanding implications. So, you know, we've often been told stories by grandparents, you know, aunts, great uncles about how you can't trust the medical system because they knew someone who died because they, you know, were working with maybe a Caucasian, you know, treatment team that really didn't listen to them or that were just experimenting on them. Um, Other reasons why mental health stigma exists is there's basically a lack of understanding of mental health issues and where it comes from. Again, some people feel that it's spiritual in nature, and I'm not saying that that's not a component of it, But if you're using spiritual interventions, again, to treat a mental health issue and it's not working, then I would hope that the conclusion would be maybe this is something else. Okay. Another reason why stigma exists is there's often a misinterpretation of mental health symptoms where you're attributing the symptoms to something that has nothing to do with that. And another reason is that sometimes we normalize mental health issues. We may see someone in our family who has substance abuse issues or who just can't handle stress well, but a lot of people around us are like that. So we think that's just normal. That's just how you handle situations. You're supposed to drink yourself under the table if you're stressed out about something because my mom did it, my uncle did it. I saw my cousins do it. Whenever they get upset or they get stressed out, they party, right? And they're under the influence, and that's just how they cope with their issues. And you think that that's just what everyone does. Another reason for stigma is shaming or feeling shame, or maybe you blame yourself for having these mental health issues. Another reason is misplaced pride. Maybe you feel like you shouldn't have these issues. I'm better than that, or I'm stronger than that, or if I have these issues, then I'm somehow weak. I often hear patients say that, so they may not want to come get treatment because they feel like they're flawed or defective because they need help outside of themselves. Now, more about the topic of African Americans' distrust of the medical community, because I think this is really big, and a lot of my non-African American colleagues don't really understand the impact of the history of this country in terms of, like I said, there have been a lot of medical exploitation of Black people in the United States. And because of that, there is a deep-seated mistrust of the medical system within the Black communities because of this country's long history of white doctors, scientists, and researchers really preying on Black people. There's actually a really good book called Medical Apartheid that I got a chance to read a few years ago. It's by an author named Harriet Washington, and it was published in 2006, and it goes into a lot of detail about America's past, and it documents a ton of really important historical events that spanned from the 18th century to the present, and it included things like medical experimentation on slaves, grave robbing, unauthorized autopsies. Of course, we know that the Tuskegee syphilis study, experiments on incarcerated individuals without their knowledge, human radiation experiments, forced sterilization. I mean, this book really just goes into great detail about just some horrific actions that were done on Black people at the hands of medical professionals. And this hasn't been forgotten, you know. And this book was such a good book that it received several awards, including the National Book Critics Circle Awards for nonfiction. And that was in 2007. And this book was even critical in leading to the American Medical Association's apology. They issued a public apology in 2008 for their treatment of Black people and of Black physicians. And they even admitted that they were being discriminatory toward a lot of the Black physicians that would try to apply to their club. So this was just a very pivotal book. And if you guys can get a copy of it, I would highly encourage you to read it. But it's called Medical Apartheid. So again, a lot of people within our community they don't trust, they just don't trust the healthcare system, especially Caucasian doctors. And really because of the treatment of Blacks by white healthcare professionals, because that was so pervasive and egregious, this distrust spilled over into Blacks not trusting the system at all, whether they had a Black provider or even a white provider or another provider of color. And even if their doctors and nurses were Black, they still didn't trust them, right? So currently there is a lot of skepticism if African American physicians, psychiatrists, or counselors can even meet their needs. Like a lot of patients don't even feel like Black providers can meet their needs. But a lot of African Americans do want to seek treatment from an African American provider, but they're not always able to because there are just not a lot of African Americans in the medical field to begin with. So just to give you an idea, out of all the physicians in the US, there are about 1 million of them. Only 4% of them are Black, and only 2% of the psychiatrists in this country are Black, and only 4% of psychologists in this country are Black. So that leaves you with a lot of African Americans who do decide to seek treatment. They're seeking it from, you know, non-Black providers. And, it's no wonder that a lot of them don't really have good follow-up, or they just don't trust the treatment plan, or maybe they don't understand the treatment plan because it's not explained to them in a way that's culturally relevant. And it really leads to a lot of bad outcomes. So there's a lot of room for improvement in terms of representation in the medical community. There is a psychologist. She's a Canadian psychologist. Her name is Dr. Monica Williams, and she's done a lot of research on the topic. And I think she sums up the sentiment that I was just talking about when she said that apprehension about clashing with values or worldviews of the clinician can cause ambivalence about seeking help. And this may be especially true for the many who believe that mental health treatment was designed by white people for white people. We know that Black people are not the only group with stigmatizing beliefs about mental health care. There are many other communities of color that also share similar beliefs. For instance, a lot of Asian people or people of Asian descent, they often feel like mental health issues are caused by evil spirits, or that an ancestral spirit is coming back to haunt the individual with the mental health issue due to past bad behavior. And some people of Hispanic descent face unique barriers that include cultural beliefs, language barriers, and lack of culturally competent doctors, nurses, and counselors. So they often experience a lot of healthcare disparities because of those issues. And another reason for mental health stigma within communities of color is just not understanding what mental health issues are or what causes them. Many people who have mental health issues are thought to, like I said before, to be faking their symptoms. People think that these people are just weak, or they're simply not trying hard enough to overcome their depression or their anxiety, and they're just not believing God enough, or they just don't have enough faith, when really it has nothing to do with that at all. Really, it's oftentimes a medical condition. Just like you can have a diseased pancreas that can lead to things like diabetes, or you can have a thyroid that's not functioning properly, your brain can actually not produce enough of the right hormones to really support your moods. And, mental illness, the vast majority of the time, is a disease of the organ of the brain itself. And this is why psychiatrists are actually physicians, because we are taught how the organ of the brain functions and how it works in relation to other organs. So oftentimes, things like depression and anxiety, which can be very debilitating, is very simply treated with doses of medications that are not very troublesome when it comes to side effects, and it's very quickly treated because it is a medical condition. So a lot of these medications are targeting those the unbalanced hormones to really help re-regulate those moods. And it's really just a matter of simply getting medication, and in some cases therapy and medication, or in some cases you just need therapy. But when it's really a condition that interferes with your daily functioning, you may also need medication, which we know there's tons of stigma involving taking a medication for the issues that I talked about before, particularly us being experimented on by the medical community over the years, or in the past. But again, the reality of mental health issues is that they are often inherited, and they can result from a traumatic experience or even be a combination of both genetics and from a traumatic experience. So say, for instance, you had a trauma where you maybe had been sexually assaulted, or you were robbed, or you lost a parent at a young age. These are all things that are not guaranteed to create mental health issues, but they can definitely tip the scales. So there is a 80% heritability in conditions such as bipolar, schizophrenia, autism, and having a close family member affected by mental illness is the largest known risk factor for a person to develop a mental health issue themselves. So really talking to your doctor about these conditions and really educating yourself, and not necessarily believing what you hear from family members or friends about mental health treatment can really be vital in getting the help that you need. So for me personally, I never thought that I would go into psychiatry, like, ever. I knew I always wanted to be a doctor, but I didn't think I would do psychiatry because I too felt it wasn't really, I thought it was almost like a pseudoscience, like it's not a real doctor. You know what I mean? But it wasn't until I experienced my own mental health issues that I really learned about the field, fell in love with the field, found out how effective it was. But it started halfway through um, my medical school career. I was in, med school is 4 years. I was in school for 2 years and did well. But between your second and third year of medical school, you have to pass the state boards or, the licensing exam. And I did not pass. And a lot of my friends did pass. And the rule at the school that I was at, which was Wayne State, was that if you didn't pass, you couldn't go on to the next year until you passed. So I literally had to sit out that whole year. And when I say I was so shamed, I had so much shame and embarrassment. Oh my gosh, it was like my world was over and I felt like such a failure. And it really tipped me over into a really bad depression and anxiety, which I think really wasn't just that. I think a lot of it definitely had to do with my upbringing. I was raised by, a parent who was a substance abuser, and there was just a lot of chaos and violence in the home. And I think that instance of me not passing just kind of, it just stirred up a lot of things because I really took that to heart. Like, it was just a really, really bad time for me. And I didn't know really what was going on. I thought that it was like a spiritual attack. So I stayed in my pastor's office. I would talk to him all the time. And I just didn't know what was going on. Like, I prayed, I fasted, I read my Bible. I was believing God, but I was not getting better. Can you guys hear me okay?
Yes.
Okay. For
Hear
some
you.
reason there was
Yes.
okay, good. So when I tell you this was like, I remember this was like 2002, 2003, and it was horrible. It was horrible. And my pastor suggested that I seek professional help because I was just in his office so much, and it just helped me so much just to talk about my issues. And that's kind of the wonder of even therapy. Just talking about your issues is very therapeutic. But the only problem with me was that I had really a more severe form of depression. So although I did get some relief from talking to someone, as soon as I was done, I was still just extremely depressed. So he said that he's like, you need to go see someone. And I didn't take offense to it. So I went and saw a counselor, and that was helpful. But I believe that person referred me to a psychiatrist, and I ended up getting on a medication. And that was the thing that just turned everything around relatively quickly for me. So I don't know. It was just a very interesting time in my life. And it just really, when I came back to medical school, because I did eventually pass my exam, um, I knew that I wanted to be a psychiatrist. Like, I just knew it. So I often say that this field chose me, you know, but it is a very wonderful field. It's very fulfilling to really see patients do well and to thrive really and to get their lives back. So I love what I do. But again, I never thought that I would do this. Never, ever thought that I would ever do this. But I really love what I do. But going back to some of the reasons that I said that mental health stigma exists and kind of relating to my own self, the misplaced pride of I can handle this myself, because for a long time I did feel like I could handle it myself, but it became very obvious that I could not. So that's when I got the help, or that's when I took the advice of my pastor to get the help. And I think that us listening to people when they encourage us to seek professional help, you know, us not taking that as a sign of weakness or that they're looking down on us is really the key to getting the help, is really being humble and willing to try something that did not work. Even if a lot of people around you feel that you are crazy or that, you know, they may look down on you, but it really makes a big difference. So getting rid of the misplaced pride, or even thinking that self-reliance is all you need. And I think a lot of that, again, is a coping mechanism that we probably got from our ancestors, because I mean, the reality is that when you know, a lot of our ancestors, when they were in slavery, they didn't have the luxury of being depressed, right? Who were they going to go to if they felt down? So that was really an adaptive coping mechanism that I think is passed down to us, that, you know, we're just going to kind of, you know, pull ourselves up by our bootstraps and try to push through it. And some people are able to do that, but it's a very difficult life. And some people just aren't able to do that. And instead of asking for help, they will suffer in silence. And then this is another interesting quote that I found from an article on mental health care for African Americans. And it basically said, through resourcefulness, African Americans have developed adaptive beliefs, traditions, and practices with the tradition of turning for aid to significant others in the community, especially family, friends, neighbors, voluntary associations, and religious figures. This strategy has evolved for the historical African American experience of having to rely solely on each other, often for their very survival. So again, we have had to rely on each other, because who could we really trust? But thankfully, things are better in terms of access to quality health care, and really having providers who aren't going to prey on you, right? So to kind of keep this idea that if I go and see my doctor, I'm going to be experimented on or over medicated, sometimes can be an overvalued belief rather than reality. Because the reality is that even if you are, say for instance, you know, you have a mental health issue and it's severe enough to need medication, no one's really forcing medications on anyone like maybe they did in the 40s or 50s. If you have a doctor or a prescriber who's trying to force you to take a medication, or who's not listening to you when you're saying, well, no, this side effect is not working, or, you know, that's not the person for you. And you have the right to find another provider. You know, you should never feel like you can't advocate for yourself or speak up. So that's what I want to say about that. Shifting gears to misinterpretation of mental health symptoms. So a lot of people don't know that what they're experiencing is a mental health symptom. So that can lead to stigma, where you're having these symptoms of depression or anxiety, but you're thinking that, oh, it's because I'm just lazy, right? Or it's because I'm a worrywart, or it's because I just want to be difficult, or I'm finding something to be upset about, when really it's something that you really can't control. And just to give you an example, if a person, for instance, has major depressive disorder, the diagnostic criteria are the following symptoms occurring for at least 2 weeks or more, and you have most of the symptoms going on at the same time. So a person who has depression, for example, will have a persistent low mood. They may even not have the low mood. They may be irritable. So irritability or, you know, plus or minus low moods, in addition to sleep difficulty, problems with your energy level, not being able to concentrate, your appetite is off, you no longer enjoy things that you enjoy, you have low motivation to get up and go in the morning, you're hopeless, you have this new onset guilt or low self-esteem. And if it's bad enough, you're having suicidal thoughts, or maybe you're even taking steps to end your life. With the exception of the suicidal thoughts or the suicidal behaviors, it may be easy to misinterpret these symptoms as being something else. Well, maybe I'm just tired, or maybe, I just need to take more vitamins, or maybe, I'm going through a phase that I don't necessarily understand. But, to really talk to a doctor, even if it's a primary care doctor, they can often help point you in the right direction. But again, not knowing what the symptoms of some mental health illnesses are is really what trips a lot of people up. So I really like to educate my patients on, some of the diagnostic criteria, symptoms, and signs to look out for. And why is learning about this topic important? So why do we even have to learn about mental health stigma? Well, I think it's important because you really need to recognize and know the factors that can get in the way of treatment, which is what stigma can do, in order to really avoid them so that you can get effective treatment. Because if you have untreated mental health issues, it can cause fractured relationships, lost wages, a lot of missed opportunities, increased morbidity, which is basically just like a decrease in the quality of life, and increased mortality, because the suicide rates in African Americans, unfortunately, are rising. And the latest stats that I saw were from 2023, which said that suicide was the second leading cause of death among African American men between the ages of 18 and I think it was 24. And that was followed by, of course, homicide. And that in the year of 2023, up to about 50,000 people committed suicide. And that was not just African Americans, but that was just kind of in the US. So that averages out to about one suicide every 11 minutes. So this is an issue. I mean, this is a real problem. Again, in the past, we weren't really affected as much with the suicide rates compared to non-whites, but now we're catching up, and it's an issue. So speaking up, getting help, recognizing the stigma, and really reaching out for help is very important. Now, a lot of people will say, well, I can't get treatment because I can't afford it, or I don't have insurance, or, I just don't know where to go. So I would say that, hopefully you have insurance. If you don't, I would say find a way to get some. I know this current administration is just making it very hard for people, even with Medicaid, or it's just very difficult. We're living in very difficult times, but there are corporations and institutions that offer free or low cost psychotherapy if you don't have insurance. And there's actually a website that I want to put in the chat that say, for instance, you live near a university, like a training university that offers low cost, basically psychological services by the trainees who go there. So these are basically psychology students or psychiatric students who are in training, and they offer therapy or even medication management at little to no cost. So there's a website that you can actually look at and see if there are any of these universities near you. Again, talking to your primary care doctor for resources is also going to be helpful. If you do have insurance, calling the number on the back of your insurance card is important. And there's also another website that I really like. It's called psychologytoday.com. And you can put your information in there as far as like your area code or your zip code. And then it'll pull up the mental health providers near you, and they tell you if they accept insurance, or if they just do out of pocket, or if there's like a sliding scale. A lot of providers are doing that sliding scale, or even offering their services pro bono. Also reaching out to 988, which used to be the the National Suicide Prevention Hotline. Actually, it still is, but the number changed. So it used to be 1-800-273-TALK, but then they made it simpler. So now it's just 988. You can call 988 for resources. You don't have to be in crisis, although if you are, they definitely want you to call 988. But that's something that you can look into. And then also people, local churches, different communities, those types of things would be important as well. So that's really the end of my talk. I just wanted to hear from you guys as to, you know, what your ideas were. For some reason, I'm having a problem finding the chat. Okay, there it is. So let me put this in here.
I will show it. Once I get it, I'll show it.
Okay.
So I want to thank you for being very candid about what you went through. That kind of helps people to understand that even though you do this type of work, you went through some issues, you know, related to what the field that you're in. So it just shows your humility, and I really appreciate that. So what I'm gonna do, I'm gonna go to the panel, but before I go to the panel, I want to ask you a quick question. Have you heard
Yes.
Dr. Frances Cresswell sing?
No, I have not.
Okay, well, I'm definitely going to share her with you. I think you would really enjoy her commentary.
Oh,
Excellent
okay.
psychiatrist, and she was really renowned. So I will share that with you. Okay, so I'm gonna go to the panel, and I'm gonna start off with Ahi, since he's responsible for you being here. I'm gonna start off with him, brother Ahi.
Yes. I'd like to say
Question, comment.
you're very, very thorough. And the two things that popped in my mind when you said we had that uncle in the basement. You don't remember cousin Henry? That was a little bit before your time. We had cousin Henry stayed in the basement at grandma's house over in Colfax. And if anybody fits that kind of description, that he does. And also about the access to the therapist. When I was talking to you and you were referring different therapists, and I expressed to you that I wanted someone in the African diaspora, someone of African descent, as a therapist and psychiatrist. The names and the people that you referred to are not in our community. I have to travel maybe about 15 minutes outside of Detroit in order to go see the therapist. And I just thought that was interesting, that the people who need it most have to travel the furthest in order to get that type of have that type of access. And this is such a wide, and it hits home because in any from being a black man, that we have certain issues, and from a genetic aspect with my brother Kevin. I don't know if you remember Kevin, and my
Mm-hmm.
child and myself, and our issues and treatments. Uh, that's a whole nother subject. But you mentioned earlier about your interest in dealing with our young people and this crisis that we're in now, this high suicide rate. Uh, I remember a time where we didn't even really associate suicide with our people because it seemed to be like a Caucasian thing, a white thing. And within my lifetime, we're looking at children between the ages of 13 and 19. 40% of them have had suicide thoughts, and the numbers have just crazy, just crazy numbers. Like about I was listening to a young lady earlier, and she was saying something like 144% increase in the suicide of our young people. And I know this has a lot to do as you were stating earlier about under-resourced mental structures, um, racism and generational wealth, being able to have that type of money where you can go and have access to that, or insurance. We're underinsured. A lot of us are underinsured. But I want to talk about, I have you talk about COVID for our young people who had to endure, I believe, a little bit more than others, from family loss, which leads to depression and anxiety during that time when they're isolated and not having a face-to-face conversations and interaction, but having to do everything on the internet. And this internet, I want to say, variable in the equation, with the social media and the bullying, and on top of that, what we have been talking about often on this podcast, artificial intelligence, where young people are actually asking artificial intelligence about certain questions about their image, their friendships, their mental health, and in essence, what they're doing is basically just talking to themselves. Where do you see, or how do we combat this this rate of suicide? How do we deal with the artificial intelligence? How do we deal with our young people and this exploding rate of suicide? What are your solutions for this?
Well, I'm not going to pretend like I have the solution. I think that, you mentioned COVID, which was about 5 years ago, and then the effects of that is just very much long lasting in terms of, the people we lost, in terms of people who are still suffering from things like long COVID, where they're still having symptoms. There wasn't a lot studied, but COVID not just affected the cardiovascular system, the respiratory system, but it had a lot of implications in terms of affecting the organ of the brain itself. So a lot of people are struggling from, I think, mental health issues, even from that. And then you have, life kept going, right? You had a lot of the racial injustices that kind of coincided with the whole COVID-19 pandemic. And then, you had tons of natural disasters. And then even within our own personal lives, we had issues that were going on. So it's just trauma compounded, right? Just trauma on top of trauma that a lot of people really just never got treatment for. And that point that I was making before about normalizing mental health symptoms, or everyone around me smokes a ton of weed, or they get drunk every weekend, that's their way of dealing with things. But we know that the effects of, certain substances, alcohol especially, but also other substances, will alter, your senses and alters your mood. So a lot of people unknowingly make their symptoms worse by using substances on top of legitimate depression. And a lot of them will kill themselves while under the influence of certain substances. I think a lot of that has to do, I think that contributes a lot to the suicide rates that we're seeing, and then also access to lethal means. I mean, there's easier access to firearms, and people just aren't doing well, and they're not seeking the help, and their symptoms are just getting worse and worse and worse, and they're trying to self-medicate, and it's just not working.
Well, I'm saying with these babies, there seems to be a lot of bullying on the social media, and they're starting to compare themselves to the standards of the social media, body image, who likes me, am I accepted, and these are not real things, and we are headed into a time where people are mixing this artificial intelligence and this social media with real tangible things, real life, and it's becoming confusing for these young people. And I think that has something to do with the increased suicide rate, and then having not really understanding artificial intelligence. Is there something in your field where you guys are preparing to combat this type of these problems?
Well, I do work a lot with, like I said, kids under the age of 18. So I work a lot with their parents, and we do encourage, responsible use of social media and really any type of screen time, to really place restrictions on that, and for parents to have those filters on the kid's phone to really know what they're doing, or prevent them from going to, these unsavory websites. But it's so pervasive that it is hard, and a lot of times the parents themselves are addicted to social media, so they're distracted. So the kid, they're distracted, they're stressed. So the easy solution is just to give the kid the tablet, or sit them in front of a TV, or give them a phone, and then they're not bothered, right? But the kid is kind of left in his own world. Like you said, it's not a real world, but they're left to really try to understand who they are. And we know that, there are tons of people out there wanting to tell them who they are, and they're lost, but I do a lot of psychoeducation with my patients and their families, really to kind of decrease a lot of the screen time, which is an uphill battle. I mean, in all honesty, I struggle with being on my phone a lot. So it's a nice stress relief, at least in the short term, but it really, there's been a lot of studies that show that it leads to even more mental health issues, sadness, loneliness, things like that. So, but I don't know. I want to hear from the other people in the audience. What do you guys think? I mean, I'm a provider, but I don't know.
I go to each person for you. Okay, D. D. I guess D, are you just listening?
Hey, I'm sorry about that. I was having difficulty trying to get off mute. So I do have a question actually, and Dr. Howell, it is with regards to an earlier question or an earlier statement that you made. You said to ask the question to someone who is experiencing mental issues if they've taken their medication. It's offensive to ask that question. So for me, it would be my first impulse to ask that question. With you being a mental health professional, what are directed, very specific questions that are appropriate to ask a person who's in crisis or who is, experiencing psychological issues, whether they've been diagnosed or not? I'd like to know because, of course, in my previous experiences with people who were in crisis, that was my first question. And it would be something that I would still ask. But I do want to be very cognizant of what is a trigger or what is appropriate to ask.
Yeah, no, that's a fair question. I listed that as being it could represent mental health stigma, because asking a person, well, have you taken your medication, assumes that the issue that they're going through could simply be solved with medication. And I often get a lot of patients who I see who they want like the magic pill or the silver bullet in a pill bottle. And I'm like, well, it doesn't really work that way. I'm just a part of your mental health team. You need to have not only a psychiatrist or prescriber who's giving you medication, but you need to be in therapy. You need to be eating right, taking care of yourself, sleeping properly, spirituality. I mean, all of those things need to be in place. So sometimes to ask a person, well, did you take your medication? It's almost like you're reducing their stress to you're equating them to a medication. I'm probably not saying that correctly, but now I won't say you can never ask that question. I think if you have a very close relationship with that person, perhaps you can ask that question. But if they're in crisis to the point where you have to question whether or not they're taking their medication, then that question may tip them over the edge. And even if they did take their medication, there are still some stressors that can override the effects of the medication. So I guess what I'm trying to say is a medication is not the all end all.
Mm-hmm.
Does that make sense?
Yeah, it absolutely does make sense. And I understand that there are dependencies, of course, to taking medication. And I know from your point of view, of course, that would include professional treatment, sleeping well, eating well, watching your stressors. So I think what would be appropriate questions to ask? Would it be
Right.
all of those questions? Would it depend on, and I know that it would, but I think I'm speaking more in general, if you're having a conversation with someone and, they're saying, I have really been experiencing suicidal thoughts lately, or I've really felt imbalanced and I don't know how to reset. I feel mentally stressed. And I feel like I need to reach out to someone and seek professional help. What would be the very specific questions that you should ask, and what is the information that you should give?
Well, I mean, if they're giving you that much information, I don't really think you have to ask any questions. I would just really, or if you did have a question, I would say, well, can I take you to the doctor or can I take you to the emergency room? Very few people are going to share with you all of that because they're probably so distressed that their mind just isn't able to put together thoughts or words. But if you think there's someone's in crisis, I would say definitely encourage them or even offer to assist them to go get treatment.
Okay.
The unfortunate truth is a very small group of medications can actually worsen sometimes mental health issues. Not every patient responds positively to a medication. I've had some patients, and again, this is very rare, but I've had some patients actually become more depressed on some of the medications that I gave them. And sometimes that can happen. Again, that's not very common, but really helping that person get to a mental health provider that can kind of assess the situation and kind of take into account all the things, because there have been instances where patients actually did not have a mental health issue. They had something medical going on, whether that was anemia, thyroid disease, adrenal insufficiency, maybe there was a head injury, and it only looked like a mental health issue. But getting them to a doctor where they can get kind of a comprehensive workup could be very helpful. Now, if it's a person who's not in crisis, but you know that they have issues, maybe gently, saying, hey, how are you doing? Checking in with them periodically, because that helps a lot. People don't think it does, but checking in with people periodically, whether that's a text or a phone call or even hanging out with them as time allows, that is actually very protective. That social support is very protective. But if they know that you're there for them, not just when they're in crisis, that can really be helpful. But it's not helpful to say things like, hey, I think you need a therapist, or, that's never helpful, because it's almost like, well, I don't need a therapist, but you do. I can't think of anyone on this earth who couldn't benefit from a therapist. So the best way to help people sometimes is to model you seeking help for your mental health issues. And mental health doesn't necessarily mean I have depression or anxiety. It just means that I'm seeking help to remain emotionally sound, or just to really help support my mental health in general.
Okay.
Yeah.
All right. Thank you so much.
Thank you. Okay, Adrianne? You like to unmute? Okay,
I don't really know. I don't know. I don't think I have a question. I can say this has been very helpful, and thank you, Dr. Howell. Um, Maybe one question I don't really know how to phrase it, but you just said something about emotional and mental. Maybe the question that I have is, how do you separate mental versus emotional? I know we're coining it mental health, but where does the emotional part come in, and where does it, where does the demarcation between mental and emotional? How do you determine that, or how does that work, so to speak?
Yeah, I think those terms are used interchangeably. I don't think there's really like a difference. Your mental health is reflected in your emotional well-being and vice versa. So I think those are just kind of, same term for different things. We all have emotional, we all have a level of mental wellness that exists on a spectrum. Some people have been blessed with very good mental health, just like there are some people who never get sick and they're very healthy. There are people who have the equivalent of that emotionally, and they have a strong constitution. I mean, they just are. And then there are some people on the other end that it doesn't take much to set them off, and we all come here in different it's a spectrum, and we often can't control how we show up emotionally for the most part. I mean, we can do things to really support our emotional health, but some people never struggle with it. Some people struggle with it all the time. And then you have some people who are in between. But the point that I'm trying to make is that we all have emotional health, that we should do things to help support it. I don't know if that answers your question.
That does. And I do have another question when it comes to children and teenagers. Um, let's say, how would you help them to promote good emotional health? Um, I know you talked about social media and some of the things surrounding um, their phones and stuff, but apart from that, how would, like, let's say, a coach kind of help their young people to kind of, we have certain exercises that we do to help them strengthen, from a physical standpoint. Is there certain things that we can kind of promote or continuously talk to them about that would help them from an emotional or mental standpoint?
I mean, yeah, if you feel comfortable enough, you can ask them if any of them have a therapist, if they feel like they need to seek therapy, if they're having issues in their life that is going on that's stressing them out. Because again, early intervention is key. If you can intervene early before things become a big fire, then that's always best. So just, daily check-ins. I mean, you spend a lot of time with them, so they know that you care about them. That in and of itself is protective. But just checking in and not being afraid to ask questions. I mean, you don't have to get in their business and say, hey, do you have depression or have you been diagnosed? But just checking in and saying, because life is difficult, I think, for everyone. So for someone to be doing well emotionally, um, is not as common as maybe it was 15, 20 years ago, just because there's just a lot going on in this world. So the default for me would be that people are needing help and needing that extra support. So just getting a feel for the room, so to speak, seeing how people are doing, checking in, and then referring them for help, referring them out for help. And I did put a few resources in the chat.
Okay,
Yeah.
thank you. Okay, Lynda? Lynda? Can you unmute? Okay, I'll come back. Cori Howell?
Hello. I did have a question that I thought of while I was listening, and I don't know if this has come up before or not. But my question is whether you know if there are any initiatives to include like mental health professionals as a part of the regular medical care team at all. Because I think it'll probably, if it was something that was brought up or something that was considered, I think it may take some of the stigma away from having a mental health professional, because it'll be a part of going to the primary care physician. You go to see your counselor, your psychologist, or your psychiatrist.
Yeah. A lot of insurance companies are pushing for that. They call it the medical model home, where they have a mental health professional, housed within the primary care doctor's office. That's actually been a big thing that they've done in the last 10 years or so. So some clinics are actually doing that. Now, as far as psychiatrists, there are so few psychiatrists in general, Black or white. People just aren't going into psychiatry. So you have a lot of nurse practitioners who are kind of, filling in the gap, so to speak, which there's a lot of controversy about the quality of care you'll get from them. But it is an issue with finding a psychiatrist if that's really what you need. But again, that we are moving in that direction. So that's actually a really good point, just kind of like a one-stop shop.
Mm-hmm.
Yeah.
Okay, thank you.
Mm-hmm.
Thanks. Okay, April?
Hi, I don't really have any questions. This is very informative. I'd say good job, and I'm just sitting and listening and learning and appreciate it. Thanks.
Hey,
Thank you.
April, thanks.
Thank you for coming. Okay, Pat?
Did I ask to be on? I don't know. But I am also enjoying listening, and I'm encouraged by a lot of things that I'm hearing. And I think that if we were receiving more information about how we deal with people who have problems, other than if we have problems ourselves, we need information on where to go ourselves. But when you have a person in your life who is constantly in and out of some kind of mental situation, and you're always maybe you're that person's resource in some way, and you want to be helpful, but it really wears you down because there's so few things that can happen for that person. It's medication, it's institutionalization, it's the kind of things that there doesn't seem to be anything to help bring them out of it. And they don't, well, I don't know how many people are living a fulfilling life, but the people that I have encountered, they don't get much joy out of life when they're in treatment for certain illnesses like schizophrenia. And then it wears the person down that does try to help them, spend time with them, understand their situation and their disease or their condition. And so I think that we all need more information to help us to help other people and to help ourselves while we're helping those other people if we choose to do that. But I found in my own family, when there's people who have mental health issues that are known, we kind of shun them or stay away from them or, reject them in a way. And I know that I have done that in the past myself, and I want to not do that. I want to be encouraging, and I want to encourage my other family members to be tolerant, not just tolerant, but just helpful and supportive of that person. So I think when there's a person like you that's talking about things that really affect us all, that we need a way to deal with it more effectively. That's kind of a personal thing, but I really appreciate the way you talk and appreciate the words that you're using that are so positive, and how directive that you are for people to go to different resources to get more information, read books, go to websites. I never do things like that, but I'm going to try to start doing them. So that encourages me a lot.
Thank you,
Well put,
Auntie.
Auntie.
Thanks for attending. Thank you.
Yeah,
Okay,
that was good.
Ernest?
The only thing I have, she just brings back a lot of memories for me, because I think in our lives we're going to get hit with this twice when you're young, because I'm at the opposite end of the spectrum dealing with dementia with my wife. And everything you described about the medication and all that is just so familiar to me because I'm going through that right now, and I have been for like the last 9 years. And with her, and I think it kind of might have started back when she was like in her mid 70s, but we didn't recognize it. Little odd things happened, and she had some property that she sold it for no reason. It was paid for, and she just up and sold it. And then we finally got her to go to the doctor, to a psychologist, to try to get a diagnosis, but we really didn't get it because she can't, at the time, she kind of lost her ability to walk. So we roll her in the wheelchair, and the psychologist comes in, and then when they start giving her the little preliminary tests for dementia, she started to get violent and and this white lady, I probably should have tried to find a black doctor, but she took off out of the room and she never came back in there. So we never really fully got a diagnosis. So, and that was in December '99, and then the COVID hit, and everything, come to a halt then. And then about February of 2000, she just lost her ability to walk. And so she's been bedridden ever since. So that's the only, it's a good thing kind of for me because I don't have to worry about her wandering off because I know where she is at all times. But then it's bad. I feel bad about that because she can't get up and maybe go outdoors or whatever. But I'm in this group where a lot of guys' wives are wandering off, so I thank God I don't have to worry about that, but like you said, it does work on you mentally, but it looks like in life sometimes we're gonna get hit with this when we're young, and at the opposite end of the spectrum, here it comes again. So, and then that seems to be epidemic because most of my friends that I know, when you start talking to them, you realize they have some family member that has Alzheimer's or dementia, or both. So that's all I had to say about it.
All right, thank you. Brother
Thank you for
Mshinda?
that.
Yeah, yeah. Good evening. Thank you for coming tonight, Dr. Howe. I appreciate the dialogue and what you have talked about and what you've done with your life. And I applaud you for that because just like you said, I don't meet too many black psychiatrists, let alone psychiatrists. But it just reminds me of back in the day in my earlier professional life. I guess you could say I was, working with young juveniles, I guess 18 and under, gang members and different people, in the system, in the penal colonies and outside on the streets and things like that. But I remember I was responsible for, addressing the court with a court report, pretty much doing a social study on a juvenile and submitting it to the court. And many, many, many times, my paperwork was accompanied with a psychological or psychiatric evaluation. Um, and so to support my disposition, in terms of what I suggested or what I felt that should happen to that particular person who was facing court action and possible incarceration or going home or going to a treatment facility, things like that. So I questioned. So we had the ability or the availability of a at that time it was the county, so they provided psychologists, generally speaking, but it wasn't too many psychiatrists, I don't think, that were on the panel. That So I had to go before a screening committee when I actually did all my homework and put together this packet. And okay, I'm going before this committee and submitting it to everyone, probably 5 or 6 people on the panel, and I'm basically addressing them, saying that this is what I want the outcome to be for this particular juvenile as far as their sentencing. And it was many times I would go outside of the county psychologist and ask for a private opinion. And it was a couple of, and I believe they could say, if I remember, it was one man in particular. He was a black psychologist. And so my whole point to the matter is that um, what was discussed with the black psychologist and myself was that, there are like some biases and discriminatory practices as relates to an outright probably institutional racism in terms of making, making a report, for instance, how this person is more inclined to commit violent crimes based on these, you know, these factors. And a lot of times it's some cultural things that might not be documented or what have you. So my whole point is, what is your opinion, or do you have any experiences, or what are your thoughts on the system as a whole as it relates to um, being accurate, like diagnosis or evaluations, especially when it comes to, and I don't know if you deal with that particular thing, but just the inherent racism or lack of care as it relates to Black people, as you said, and also people of color.
So what was your question? You wanted me to comment on what specifically? I'm sorry.
Just racial bias in
Oh,
evaluating
okay.
and diagnosing Black people.
Oh, there definitely exists bias, even among Black providers. I think really having the boldness to talk to your provider if you feel like there is biases going on, and not being afraid to switch providers if you feel like it's not a good fit because of those reasons. But yeah, there's definitely biases, and that can definitely interfere with treatment for sure.
Okay.
Yep.
Okay, thanks a lot. All right, Professor Rahh?
Yeah. Again, appreciate you coming on the program, Dr. Howell. We deeply appreciate your analysis, your presentation, and appreciating what you've discussed about understanding correctly. I just have a couple of questions, if you don't mind. Have you, is there a brief system that make a delineation from a psychological problem and a psychiatric problem? Is there a criteria or a standard in your studies? Or I mean, some people can be trying to treat a person with a psychological problem when it's a psychiatric problem.
Yeah.
So treating a psychiatric problem when it's a psychological problem.
There is a lot of overlap between those two worlds. So psychologists treat there's the idea of there being a difference between the brain and the mind. So you can look at psychology as involving the mind and psychology as involving the organ of the brain. So the organ of the brain houses these structures in the brain that has to do with psychology. So say, for instance, you had mild depression, anxiety that responded to psychotherapy alone, then it's probably wasn't a medical or biological problem. Whereas if you're, throwing the kitchen sink at a person, they have major depression, or, there's a lot going on there, they're not responding to therapy, they're not responding to medications, then that person would need a full workup, including lab work, maybe some neural imaging, CAT scans, whatever, to just see if there's something else going on. But there's a very intimate connection between the mind and the physiology of that person as a whole. So a lot of times you can't tease those two things out unless you take a very detailed history, or unless there's something kind of obvious going on with that patient, meaning they're not getting well with the evidence-based treatments that are offered.
Okay, now what I'm saying is that in treating someone with a psychiatric problem, how do you determine it's a psychiatric problem? Through blood tests or through the various symptoms that they illustrate? I mean, because see, you know, like you say, it's the brain, it's inside the head.
Mhm.
You know, like you can tell if a person has a stroke or if a person has some of the various. Would you count dementia or amnesia as psychiatric or psychological?
Well, it's based in the organ of the brain. So yes, you are correct. So it's psychiatric, but it can cause psychological problems because it's touching on the areas of the brain structure that affects things like mood regulation, impulsivity. And Mr. McBride, you were talking about your wife. You know, she has dementia. Dementia is an organ of the brain itself. It's a disease of the organ of the brain itself, but it manifests with a lot of psychological symptoms, mood swings, impulsivity, anger outbursts, probably, and just some very bizarre behaviors. So really having the correct diagnosis can point you in the right direction. But if you just look at a person's psychological symptoms, you really can't know if it's psychiatric or psychological. And oftentimes you don't necessarily have to make a distinction between those two things because you can kind of treat both at the same time.
Do CAT scans help you determine a psychiatric problem or a psychological problem?
Only
Brain
post-mortem. Not always. I mean, there are a lot of tests and studies that have found that people with schizophrenia, for example, do have decreased brain mass, um, you know, and even people with dementia, oftentimes their brain volume does decrease, but you can't look at a CAT scan and say whether or not a person is struggling with anxiety, depression, bipolar. The technology isn't there yet, but I think it's definitely moving in that direction.
In your practice, do you practice, have your own practice, or are you working with a hospital or your own facility?
I work for a clinic based in Virginia. So yeah, I work for a private agency.
And you get referrals?
Our referrals come through Medicaid. So the company that I work for, they deal specifically with young people who have had repeated hospitalizations, just high risk behaviors, and they're trying to really keep them out of the hospital. So all the patients that I see are referred through Medicaid. So I don't get referrals. I just see the patients that are given to me. So no, I don't
Okay.
I don't accept referrals.
My other question is, have you is there any in your studies of these patients that you have, and I don't know how many were African Americans and people of color. Yeah, have you ever ran across unique mental problems that related to that specific race because of the the way the system has put them through? I mean, they have a unique mental challenge because of their experiences or family experiences in the society that is unique. Not all of us go through depression. Many people, all races have narcissism, and all races have various general what do we call general psychiatric and psychological issues that are in common. But have you ever ran across unique behavioral issues among Black people specifically?
I wouldn't say unique. I'd say they're probably more severe. Their symptoms are probably more severe just because oftentimes, Black people are relegated to the inner cities, and inner cities typically have a lot of crime, stress, you name it, food insecurity issues, food deserts, just a lot of trauma, you know, and the severity of the symptoms of African Americans when they present are often, more pronounced than maybe a non-Black counterpart. But as far as unique diseases that are just specific for African Americans, I'm not aware of those.
Okay. Now the other thing is, do you teach any classes in psychology?
No.
Okay. Have you ever taught them?
Periodically, not like an actual course.
Mm.
Yeah.
Okay. All right. The other thing is, have you ever heard of the term oppression psychoneurosis?
No.
Well, that's from a term introduced by Dr. Naeem Akbar, who was a psychologist out of the University of Florida, professor and a practicing psychologist. He wrote a number of books, but he introduced that term, oppression psychoneurosis, the role of oppression. Like the witnesses of George Floyd being choked to death, or the people that went through Tulsa, Oklahoma. I mean, they may have some trauma that's caused by specific racial prejudicial behavior that, that cause, some deep trauma and deep depression, deep reaction. Have you ever had to treat people in that area?
No, I did write that down though. I'm gonna look that up.
Okay.
Yeah, I'm gonna have to look that up.
Oh yeah, the other thing is that, are you a member of the Association of Black Psychologists, National of the Association of Black Psychologists?
No.
Okay, there is a national organization called the Association of Black Psychologists, because you have to network. Like you say, it's not that many in the field, and so you try to put it together. Whereas people can refer people to them because they have a central methodology within, and they have annual conferences and things of that nature. But
Okay.
what about male-female relationships? We're supposed to be attracted to our species have. I mean, that's man and woman. I'm not talking about people that's into transgender or homosexual or lesbian and gay behavior. That's separate. I'm talking about from the standpoint of just male-female relationship, whereas you have an enormous amount of conflict that have led to people, like in the 40s and the 50s, Black men specifically wanted to get married. You understand? I mean, that's why you have a lot of parents that got married in the 40s and the 50s. That was a goal. That was part of your manhood, part of your womanhood, and you look toward each other. Seems like today there seems to be an enormous amount of conflict with regards to people not even thinking like that. And is that a mental problem? And what role do you think culture plays in mental illness or acculturation?
Okay, I don't know if I understood your first question about the male-female relationships, but
Well, okay, I'm getting this done. There are women that will never be asked to get married today.
Mhm.
Whereas back in the 40s and the 50s, they got married at an early age. That means they got 13, 14, 16 in the South specifically, where the majority of Black people live. And, they had big families. Is that fair to say? And during the Black migration, they came into urban areas in the cities in Chicago, St. Louis, Philadelphia, and all of those things. But now today, it seems to be abnormal for people to pursue mating and children as a part of procreation and a part of desires to have a mate, longevity in their mating relationship. And is that abnormal? I mean,
I mean, you probably have to ask a sociologist that question. I don't, if
no,
anyone else in the audience has an answer for that one, I think it would be specific to that individual. I mean, if they consider being single normal, that would be, and then if they wanted to get, I don't know. I think it's a personal preference.
But okay, let me ask you this. Is it normal for a man to say, I don't want to be married to no woman, and a woman to say, I don't need no man, I just have a baby and I'll raise it myself? Is that normal behavior?
I would need to know. I would need to.
So
I don't know. I mean, it could be adaptive behavior, but normal or, I mean, again, I have no clue. I mean, some people do well by themselves. Some people do better as a couple. It really depends on that person, you know.
Okay, okay.
It's sure today's normal, that's for sure.
Okay, thank you. Oh, and just another thing. Do you think, this last question,
Okay.
do you think that misogynist rap songs and vulgar, violent rap songs influence negative behavior?
I think anything you consume that's positive or negative will influence you in ways that you may not always be aware of. So absolutely.
All right, thank you.
Yes, of course.
All right, thanks, Professor Rahh.
All righty.
Well,
It's
that was
good.
interesting.
Yeah.
So, is there anything else you want to leave us with this evening, Dr. Howell?
Yes, don't be afraid to reach out for help, even if it's just to one trusted person, even if you're just talking to them about whatever mental health issue you're going through. But don't let it be a pattern where you're just always going to that one person talking to them. I guess I would say don't bootleg your life. You need mental health you need mental health treatment, just like you need a primary care doctor. I think everyone should have some form of a mental health professional helping them. So don't think you can get everything you need from a friend, family member, because they often are going through their own issues. So really be responsible and take charge of your own life. And that often starts by getting help for your mental health issues, and don't stop at the first barrier that you get to, because there will be barriers, but keep pressing for it, ask for help, and keep asking for help because help is available.
Okay, well, that's good advice. I've been hearing that from other professionals in the field of psychology. So excellent. I really appreciate you coming on this evening and sharing with us.
Thanks for having me. I enjoyed it. Thank you so much.
If you ever want to come back, we will definitely want you to do that.
Thank you so much.
Thanks.
Thank you.
Thank you.
So,
thank you so much.
Appreciate it.
And I want to talk to you right when we finish, so don't leave, please.
Okay.
Professor Rahh, do we have anything for next Tuesday?
I'll call you tomorrow.
Okay. So next Wednesday, we have Terrence McMillan. He's a real estate agent. So the topic will be real estate and generational wealth. Open to the public. Anybody want to come and join us? If anybody else want to be a guest, just contact Ahi. So I appreciate everyone coming this evening, and I want everybody to continue to have a great day. Each one teach one in Conscious Corner.
Thank you. Have a good night.
Yeah, you too.
Thanks, everybody.
You.